Bismillahirrahmanirrahim. The topic of our discussion today is VTE in pregnancy. Basically, I will be discussing RCOG Guideline 37A and B. So, let us start. Venous Thromboembolism prophylaxis in pregnancy and puerperium. 37A RCOG guideline. Okay, so this appendix is very important, in which we are shown the pre-existing obstetric risk factor and the new onset transient risk factor. Okay, in the pre-existing risk factor, we have, when we discuss the previous VTE, it would be better if we discuss thrombophilia, which include heritable and acquired type of thrombophilia. The heritable thrombophilia includes antithrombin deficiency, protein C deficiency, protein S deficiency, factor V laden, and prothrombin gene mutation. The acquired conditions of thrombophilia include antiphospholipid syndrome, persistent lupus anticoagulant, or persistent moderate high titer anticardiolipin antibodies and or beta-2 glycoprotein 1 antibodies. Okay, we may have certain medical comorbidities like cancer, heart failure, active SLE, inflammatory polyarthropathy or IBD, nephrotic syndrome, type 1 diabetes mellitus with nephropathy, sickle cell disease, current intravenous drug users, age more than 35, obesity, with a BMI more than 30 kg per meter square, either pre-pregnancy or in early pregnancy. Parity more than 3. Women become para 3 after her third delivery. Smoking, gross varicose vein, symptomatic or above knee, or with associated phlebitis, edema or skin changes, paraplegia. Okay, now certain obstetric risk factor includes the multiple pregnancy, current preeclampsia, cesarean section, prolonged labor that is more than 24 hours, mid-cavity or rotational operative delivery, stillbirth, preterm birth, and postpartum hemorrhage of more than 1 liter requiring transfusion. Then we may have certain new onset or transient risk factor. These factors are potentially reversible and may develop at the later stages in gestation than the initial risk assessment, or may resolve, and therefore what is important is an ongoing individual risk assessment. Okay, so in the transient risk factor, we have any surgical procedure in pregnancy or puerperium except immediate repair of perineum, that is appendectomy, postpartum sterilization, and bone fracture. Okay, so any surgical procedure would be included among the transient risk factor. Hyperemesis gravidarum is also a transient risk factor. Ovarian hyperstimulation syndrome is also a risk factor. Here it is very important that it is about the first trimester only. Okay, admission or immobility of less than 3 days, bed rest, current systemic infection requiring intravenous antibiotics or admission to the hospital, long distance travel of more than 4 hours, okay, and then assisted reproduction technique, ART, in vitro fertilization, IVF. Okay, and about the admission or immobility for more than 3 days, we have example like pelvic girdle pain, restricted mobility, and current or systemic infections includes the pneumonia, pyelonephritis, postpartum wound infection. Okay, and now let us discuss the doses of enoxaparin, dalteparin, and diazeparin based upon the weight of the patient. Okay, if we have less than 50 kg, then we give 20 mg enoxaparin daily, or 2500 unit daily dalteparin. Diazeparin we give 3500 units daily. Okay, weight we when the weight is 50 to 90 kg, we give enoxaparin 40 mg daily and dalteparin 5000 units daily and diazeparin 4500 units daily. When the weight is 91 to 130 kg, we give enoxaparin of 60 mg daily and 7500 unit daily of dalteparin and 7000 unit daily of diazeparin. When the weight is between 131 to 170, we give enoxaparin of 30 mg and dalteparin 10,000 units daily and 9,000 units daily of diazeparin. Okay, and if the weight is more than 170 kg, then it's very important that we give 0.6 milligram per kg per day of enoxaparin, 75 unit per kg per day of dalteparin, 75 unit per kg per day of diazeparin. And high prophylactic dose are given for those women weighing 50 to 90 kg. Okay, so enoxaparin we give 40 mg 12 hourly, dalteparin we give 5,000 units 12 hourly, and diazeparin we give 4,500 units 12 hourly. Okay, so after that, let us come to the appendix, obstetric thrombolysis risk factor and management. Okay, antenatal assessment and management to be assessed at booking and repeated if admitted. Okay, so if we have any previous VT except a single event related to the major surgery, we include those patients among the high risk group who require antenatal prophylaxis with a low molecular weight heparin, and we refer them to the trust nominated thrombosis in pregnancy, that is the expertine. Okay. And among the intermediate risk group, we consider antenatal thromboprophylaxis with low molecular weight heparin. And among those patients, we include those who require hospital admission, single previous VTE related to the major surgery, high risk thrombophilia plus no VTE, and medical comorbidities like cancer, heart failure, active SLE, IBD or inflammatory polyarthropathy, nephrotic syndrome, type 1 or type 1 diabetes mellitus with a nephropathy, sickle cell disease, current intravenous drug user, then any surgical procedure like appendectomy, and ovarian hyperstimulation syndrome, in which we consider first trimester only. Okay. So after that, let us come to another group in which we have obesity, BMI more than 30 kg per meter square. Okay, and age more than 35, parity more than 3, smoker, gross varicose vein, current preeclampsia, immobility, for example, paraplegia, or family history of unprovoked or estrogen provoked VTE in the first degree relative, low risk thrombophilia, multiple pregnancy, IVF, and ART. Okay, for these group of patients, we would like to say that if they have 4 or more risk factors, then we will start prophylaxis from the first trimester. If we have 3 risk factors, we start prophylaxis from 28 weeks. And if you have fewer than 3 risk factors, we will consider them as a low risk and we will start mobilization and avoidance of dehydration. Okay, now coming to the transit risk factor. Transit risk factor include dehydration, hyperemesis, current systemic infection, long distance travel. Okay, so these are the patients who don't need thromboprophylaxis throughout the pregnancy, but in the transit phase when they are admitted or in certain conditions they are given thromboprophylaxis. Okay, so now coming to another chart of the RCOG Guideline 37A, that is about the postnatal assessment and management, that is to be assessed on the delivery zone. Okay, when the patient delivers a baby, after that we do proper assessment of that patient, and depending upon that assessment, we give proper dose of thromboprophylaxis. Okay, like first of all, the red one are those patients who are included among the high risk. Okay, high risk patients are these. Okay, those patients who have any previous VT. Okay, secondly, anyone requiring antenatal low molecular weight heparin, high risk thrombophilia, low risk thrombophilia plus family history. Okay, high risk thrombophilia of the patient herself, and if she is having low risk thrombophilia associated with the family history, then still we will consider her among the high risk group. Means we will give her at least 6 weeks postnatal prophylaxis with the low molecular weight heparin. Now coming to the intermediate group, okay, you can see the orange box, okay, which patients will be included. First of all, cesarean section in labor. So you can see the reference in the lower box that we have elective cesarean section. So elective cesarean section is not included among the intermediate risks, that those are certain minor risk factors. And if we have cesarean section in labor, we will consider the patient among the intermediate risk. Okay, and if you have BMI of more than 40 kg, again see the difference in the lower box, we have BMI of more than 30 kg, and in the top box, in the middle box, which is included in intermediate risk, we have BMI of more than 40 kg per meter square. So the best thing is that you should read the guideline, but it would be better if you do comparison as well. In that way, you will remember it very easily. Okay. Now, another point is about readmission or prolonged admission more than 3 days in the puerperium. Okay, and any surgical procedure in the puerperium except immediate repair of the perineum. Okay, and medical comorbidities like cancer, heart failure, active SLE, IBD, or inflammatory polyarthropathy, systemic syndrome, type 1 diabetes mellitus with the nephropathy, sickle cell disease, and current intravenous drug users. So all these are intermediate risk risk patients. Okay, and to them we give at least 10 days postnatal prophylaxis with a low molecular weight heparin. If these risk factors are persisting or more than 3 risk factors are present, consider extending prophylaxis is with the low molecular weight heparin. Okay, so the thing is that if we have more than 3 risk factors, okay, or if we have persistence of these symptoms, that we will increase the dose of low molecular weight heparin, or we can extend the dose of low molecular weight heparin. Now coming to the lower box, in which we have age more than 35 years, obesity, that is BMI more than 30 kg per meter square, parity more than 3, smokers, elective cesarean section, family history of VTE, low risk thrombophilia, okay, and gross varicose vein, current systemic infection, immobility like paraplegia, okay, and long distance travel, current preeclampsia, multiple pregnancy, preterm delivery in the previous pregnancy, that is less than 37 weeks, stillbirth in this pregnancy, mid-cavity rotational or operative delivery, prolonged labor for more than 24 hours, PPH of more than 1 liter, or blood transfusion. Okay, so if we see these risk factors in the patient, and if we had 2 or more risk factors, we will consider the patient among the intermediate risk group. Okay, and if we have fewer than 2 risk factors, then we will consider the patient among the lower risk. We will only suggest early mobilization and avoidance of dehydration. Okay, now risk assessment for venous thromboembolism. This is another chart, another appendix. It is written that if total score is more than 4 antenatally, consider thromboprophylaxis from the first trimester. Okay, means if we have in the antenatal period, if we have more than 4, we will consider thromboprophylaxis from the first trimester. If the score 3 antenatally, consider thromboprophylaxis from the 28 weeks. Okay, and if score more than 2 postnatally, consider thromboprophylaxis for at least 10 days. Okay, and if admitted to the hospital, consider thromboprophylaxis. Okay, and if prolonged admission more than 3 days or readmission within the period, consider thromboprophylaxis. Okay, and for a patient with identified risk, bleeding risk, the balance of the risk of the bleeding and thrombosis should be discussed in consultation with hematologist with expertise in thrombosis and bleeding in pregnancy. Now, risk factors for VTE, we have certain pre-existing risk factors. Previous VTE except a single event related to major surgery, we will give score 4. Previous VTE provoked by the major surgery, score 3. No, non-high risk thrombophilia, score 3. Medical comorbidities like cancer, heart failure, active SLE, inflammatory polyarthropathy or inflammatory bowel disease, nephrotic syndrome, type 1 diabetes mellitus with a nephropathy, sickle cell disease, current intravenous drug user, we will give score 3. Now, family history of unprovoked or estrogen-related VTE in the first degree relative, score 1. Low risk thrombophilia, score 1. Age more than 35, score 1. Obesity, score 1 or 2. Parity more than 3, score 1. Smoker, score 1. Gross varicose vein, score 1. Okay. Then if we have obstetric risk factors like preeclampsia in the current pregnancy, score 1. ART or IVF, score 1. Multiple pregnancy, score 1. Cesarean section in labor, score 2. Elective cesarean section, score 1. Mid-cavity or rotational operative delivery, score 1. Prolonged labor for more than 24 hours, score 1. PPH 1 liter or more than 1 liter or transfusion, score 1. Preterm birth less than 37 weeks in the current pregnancy, score 1. Stillbirth in current pregnancy, score 1. Now, coming to the transient risk factor, any surgical procedure in pregnancy or puerperium except immediate repair of the perineum, for example, appendicectomy or postpartum sterilization, we will give score 3. Okay, hyperemesis, score 3. Okay, so that is about the transient risk factor. We included certain patient among the transient risk factor, but among the transient risk factor, we will give different scoring. Hyperemesis score 3, and intermediate risk, so we will give thromboprophylaxis from 28 weeks, but also in the hospital admission. Okay. Sorry, not in 28 weeks. Hypermesis is in first trimester, and we will give thromboprophylaxis during the hospital admission. Now, ovarian hyperstimulation syndrome, first trimester only. We give score 4 to them. Systemic infection, score 1. Immobility or dehydration, score 1. Now, there are certain contraindications to the use of low molecular weight heparin, which include known bleeding like hemophilia, von Willebrand disease, or acquired coagulopathy, active antenatal postpartum bleeding, women considered increased risk of the major hemorrhage, thrombocytopenia, acute stroke in the previous 4 weeks, and severe renal disease, severe liver disease, uncontrolled hypertension. Okay, now very high risk and high risk, intermediate risk, low risk. We have certain group of the patients. Okay, who are among the high risk group? Okay, previous VTE on the long-term oral anticoagulant therapy. Okay, if the patient is already on anticoagulant therapy and she had previous VTE, then she is included among the high risk group. Or if we are having certain thrombophilia like antithrombin deficiency, antiphospholipid syndrome with the previous VTE. Okay, what we will do, recommend antenatal high dose low molecular weight heparin and at least 6 weeks postnatal low molecular weight heparin, or until switch back to oral anticoagulant therapy. Okay, these women require specialist management by the experts in hemostasis and pregnancy. Now, high risk, any previous VTE except a single VTE related to the major surgery, recommend antenatal and 6 weeks postnatal prophylaxis with low molecular weight heparin. Now, intermediate risk, asymptomatic high-risk thrombophilia, homozygous factor V, leading compound heterozygous protein C and S deficiency, and single previous VTE associated with a major surgery without thrombophilia, family history or other risk factor. What we'll do, we will refer to the local expert, consider antenatal low molecular weight heparin, recommend postnatal prophylactic low molecular weight heparin for 6 weeks, and consider antenatal low molecular weight heparin but not routinely recommended, and recommend low molecular weight heparin from 28 weeks of gestation and 6 weeks postnatal thromboprophylaxis. Low risk are asymptomatic, low risk thrombophilia, prothrombin gene mutation or factor V laden. We consider as a risk factor and score appropriately. Recommend 10 days if other risk factors postpartum, or 6 weeks if significant family history, or postnatal prophylactic low molecular weight heparin. Now, thromboembolic disease in pregnancy and puerperum, acute management. How would we do acute management? How would you do diagnosis of acute venous thromboembolism? How is it diagnosed in pregnancy? Okay, objective assessment and diagnosis is very important, and we don't have to give low molecular weight heparin when objective testing for diagnosis exclude diagnosis or low molecular weight heparin is contraindicated. Okay, and there should be hospital protocol for VTE objective testing, which include the multidisciplinary team of doctors like hematologist, physician, obstetrician, and radiologist. And what investigations are needed for diagnosis of an acute DVT? Acute DVT, we do the compression duplex ultrasound, and if the ultrasound is negative but there is low suspicion of low clinical suspicion of DVT, we do not give the low molecular weight heparin because both things are negative. But if ultrasound is negative but we have high suspicion of low molecular weight heparin, we do not give there is high suspicion of DVT, but we do not give low molecular weight heparin, but we repeat ultrasound on day 3 to 7. Okay? And what investigations are needed for the diagnosis of acute pulmonary embolism? When a patient is having acute pulmonary embolism, chest X-ray and ECG both are done. Then, if we have suspected pulmonary embolism plus sign of DVT, and we do duplex ultrasound, and that confirms the DVT, we give enoxaparin. Okay, but if we have suspected pulmonary embolism and no sign and symptoms of DVT, we just suggest the CTPA or VQ scan. We do not suggest the Doppler ultrasound of the leg. Okay, now if we have abnormal chest X-ray and clinical suspicion of the DVT, then we suggest we prefer CTP as compared to VQ scan. Okay, but if the VQ scan is normal and ventilation perfusion scan is normal, but clinical suspicion of the DVT exists, we give alternative or repeat testing plus low molecular weight heparin. Okay. Now, it's very important that the VQ scan is associated with increased risk of the childhood cancer and low risk of the maternal breast cancer. Okay, so it is mother friendly. Okay, and relative risk low in both cases. The relative risk are both low in both cases. Okay, and there has been a lot of study on the VQ scan and CDPA. And it's very important that whenever we suggest that there should be proper counseling of the patient and informed consent should be taken. How does D-dimer testing be performed prior to objective testing? Okay, if we suspect the acute pulmonary embolism, thromboembolism in pregnancy, do not recommend D-dimer. Okay, because the D-dimer is not very specific in pregnancy. What is the role of pre-test probability assessment? Pre-testing probability assessment in the VTEs has no role. Now, baseline blood investigation. What baseline blood investigation should be performed before initiating anticoagulant therapy? Okay, before starting anticoagulant therapy, we recommend full blood count, coagulation screen, urea and electrolyte, liver function test. Okay, and do we recommend thrombophilia screen? No. And initial anticoagulant treatment of VTE in pregnancy. What is the initial treatment of VTE in pregnancy? That is a question. Okay, we should start low molecular weight heparin unless objective testing for the diagnosis exclude the diagnosis or the enoxaparin is contraindicated. Now, what is the therapeutic dose of low molecular weight heparin in the pregnancy? Okay, it's very important that the low molecular weight heparin should be titrated against the pre-pregnancy weight, and whether we give single dose or double dose, that is important. There should be hospital guideline for low molecular weight heparin dosing and what tests should be performed to monitor heparin therapy in the pregnancy. Routine anti-XA level is not recommended unless women at extreme of the body weight less than 50 kg or 90 kg or more, or with other complicating risk factors, for example, with a renal impairment or recurrent VTE. We do not recommend platelet monitoring in routine. Okay, now when we give low molecular weight heparin, after every 2 to 3 days we check the platelets and from day 4 till day 14. And how should massive life-threatening PE in pregnancy and puerperium be managed? Okay, that is by the team of clinician and consultant, and individual basis of the patient management should be done in a very appropriate way. There can be only heparin or thrombolytic therapy or surgical thrombolectomy. So that is depend upon the individual circumstances and after discussion with the consultant. The senior physician should be involved in the care of the patient, that a multidisciplinary team includes the obstetrician and the radiologist. Okay, and if we have massive pulmonary embolism with the CVS involvement, we should give low molecular weight heparin. And maternity guideline should be there in every hospital for admission of the for administration of the unfractioned heparin, and there should be a team of doctor who should be a team of nurses, multidisciplinary team who should be available, and the phone call facility should be there. Okay, then ECG and CTPA confirms the thromboembolism, then the massive pulmonary embolism, if that is diagnosed, then within 1 hour we should consider immediate thrombolysis. Additional therapies should graduated elastic compression stocking be employed in the acute management of venous thromboembolism in pregnancy. Initial management includes mobilization and stocking. Okay, what is the role of inferior vena cava filter in the management of the VTE in pregnancy? Okay, consideration should be given to the use of temporary inferior vena cava filter in the peripartum period for the patient with iliac vein VTE to reduce the risk of pulmonary embolism in patients with a proven DVT and who have recurrent pulmonary embolism despite adequate anticoagulation. Now, how would we do maintenance treatment of VTE? What are the maintenance treatment for DVT or PE? When therapeutic dose of low molecular weight heparin is given in pregnancy plus puerperium 6 weeks postpartum or until 3 months treatment. So that is the recommendation. And the patient should be taught how to do self-injection and how to discard the sharps. How do you do outpatient monitoring? We do clinical assessment, platelet monitoring, and peak anti-XA levels. Okay, heparin-induced thrombocytopenia symptoms should be taught to the patient, and a doctor should be able to recognize the heparin energy and whether she is requiring a continuous anticoagulants or not, and consider alternative anticoagulant. Can vitamin K antagonist be given during pregnancy for the maintenance treatment of the VTE? About this is written, no, we shouldn't give the heparin because of the teratogenic effects. Is there any role of anticoagulant treatment in the treatment of VTE in pregnancy? Okay, newer anticoagulants like fondaparinux, agatrobon, or H-herodin have been considered. Anticoagulant therapy during labor and delivery. Should anticoagulant therapy be altered during labor and delivery? About this, it's written that if patient is having VTE at term, we should consider the intravenous unfractionated heparin. And when the patient is in established labor, do not give heparin. Okay, when we are planning the delivery or induction of the labor, we have to stop heparin 24 hours prior to the delivery. And low molecular weight heparin should not be given at least 24 hours before planning for epidural or spinal anesthesia. Okay, and after epidural, within 4 hours, low molecular weight heparin should not be given, and epidural catheter should be removed at least 12 hours after the spinal or epidural anesthesia. Are specific surgical measures required for the anticoagulated patients undergoing delivery by cesarean sections? When we have abdominal and rectus wound drain, we should apply interrupted suture to allow drainage of hematoma. And what anticoagulant therapy should be applied in the woman at high risk of the hemorrhage? Any woman who is considered to be at high risk of the hemorrhage and in whom continued heparin treatment is considered essential should be managed with the intravenous unfractionated heparin until the risk factor for hemorrhage have been resolved. Now, postnatal anticoagulation. How should anticoagulation be managed postnatally? Okay, therapeutic dose of the low molecular weight heparin in pregnancy and perineum are given 16 weeks postpartum or until 3 months. Treatment should be given. Okay, the choice depends upon the patient as well. We should discuss with the patient, and for the first 10 days of anticoagulation, we have to do proper monitoring. Now, basic thing is that women should be offered the choice of low molecular weight heparin or oral anticoagulant for postnatal therapy after discussion about the need for regular blood test for monitoring of the warfarin, particularly during the first 10 days of the treatment. Now, postpartum warfarin should be avoided until at least 5th day or longer for women at increased risk of the postpartum hemorrhage. Now, both low molecular weight heparin and oral anticoagulants are safe in breastfeeding. Now, how to do prevention of the post-thrombotic syndrome? What measures can be employed to prevent the development of the post-thrombotic syndrome? Okay. If you give enoxaparin for more than 12 weeks, there is the risk of post-thrombotic syndrome, although it's a lower risk. Now, following DVD, a graduated elastic compression stocking should be worn on the affected leg to reduce the pain and the swelling. And what is the role of compression stocking? The role of compression stocking is in the prevention of post-thrombotic syndrome, although the proper role is unclear. Now, how will we do postnatal clinic review? Postnatal clinic review is done in obstetric medical clinic, joint obstetric hematology clinic. Now, thrombophilia testing should be performed once anticoagulant therapy has been discontinued, only if it is considered that the results would influence the patient's future management. Now, coming to some certain exam question, you're writing a guideline about the prevention of venous thromboembolism in pregnancy, and you need to include information on the background epidemiology. What is the overall incidence of the VT in pregnancy? The different risks, the different numbers are given. The answer is 1 to 2 per 1,000. Okay, and explanation is that the clinical diagnosis of VT is difficult in pregnancy, but prevalence up to 10 times higher than in non-pregnant women of the same age. An obstetric unit with 5,000 deliveries a year would expect to see 5 to 10 cases a year. Okay, now the question: postpartum thromboprophylaxis is indicated within We have three choices: 6 to 12 hours after delivery, 12 to 24 hours after delivery, and within the 6 hours. The answer is 6 to 24 hours after delivery. Another question: patient with a history of VTE, on evaluation, she has raised factor XA deficiency. Of which of these is the cause? Her mother and sister have thrombophilia. So the different factors are antithrombin 3 plasmin activator, plasminogen activator protein S and protein C. So the answer is antithrombin 3 deficiency. Another question, an EMQ where the different options are given. Let us come to the question. A 29-year-old primary gravida who is known to be heterogeneous for factor 5 laden, she has no other risk factor. So what will be, as she is already having the thrombophilia? So what would be the answer? Answer is I. Prophylactic dose with low molecular heparin once a week postnatally, because she is not having high risk thrombophilia. Okay, now another question: 24-year-old primary parents with no history of thromboembolism but is known to have homozygous for factor 5 laden. She has no other risk factors. So the answer is prophylactic dose with low molecular weight heparin and 6 weeks postnatally. So in the previous case, she was heterozygous for factor 5 laden. Now here she is homozygous for factor 5 laden. Another question: 25 years old woman intending to commence the combined contraceptive pill wishes to discuss the risk of the venous thromboembolism. She has no other risk factor for VTE, which